Welcome to the funnel effect. We are diving deep today into something that's really shaking up cardiology, I think. It's this whole idea of chronic inflammation, not just being related to cardiovascular disease, but actually, driving it. It feels like a pretty massive shift away from just focusing on cholesterol, right? Moving us into a new phase of thinking about heart risk. Our main guide for this is the brand new 2025 ACC Scientific Statement on Inflammation and Cardiovascular Disease. It's a major report from the American College of Cardiology. And this isn't just theoretical stuff. The statement is packed with what they call clinically actionable guidance. It's put together by a top-notch team. The chair is George A. Mensah, MD, FACC, and the committee includes Natalie Arnold, MD, Samantha D. Prabhu, MD, FACC, Paul M. Ridker, MD, MPH, FACC, and Francine K. Welty, MD, PhD, FACCs. So our mission today is really to boil this down for you. We want you to quickly get the core updates, understand why inflammation is now front and center, and crucially, how we actually measure and manage this risk in practice.
Yeah, and if you had to take that whole dense statement, it's quite long, and really crystallize it, it boils down to this. The link between inflammation and specifically atherosclerotic cardiovascular disease. It's not just a hypothesis anymore. We're past the exploratory phase. For a long time, it was, oh, that's interesting. Inflammation seems to be involved. Now the evidence is overwhelming. This statement itself says, quite forcefully, the time for taking action has now arrived.
Wow, so no more waiting around.
Exactly. It's basically a call to arms for doctors. Start screening, start measuring, start treating this inflammatory component.
Yeah, let's dig into that shift. For, well, decades, lipids were king, right? LDL, HDL, triglycerides, that was the main story. High LDL, bad. Low LDL, good. Simple. But obviously that wasn't capturing everything. People with good cholesterol were still having heart attacks. So why has inflammation suddenly vaulted into this starring role?
Well, precisely because that old model was incomplete. We hit a wall. Lowering LDL cholesterol is incredibly important, don't get me wrong, but it wasn't eliminating all the risk, not even close. What the research, especially over the last, say, 15, 20 years, has hammered home is that this chronic low-grade inflammation isn't just a bystander. It's not just a marker of atherosclerosis. It's actually the engine driving the process at every single step.
Every step. How so?
It helps initiate the plaque in the first place. It dictates how fast that plaque grows, how unstable it becomes. And this is critical. It's what triggers the plaque to rupture. And that rupture leads to the blood clot, the thrombogenesis, which is the heart attack or the stroke.
Ah, okay. So if LDL is like the bricks and mortar for the plaque.
Inflammation is the construction crew, the demolition team, and maybe even the earthquake that makes the building collapse. It's the active process.
That's a really helpful analogy. So the disease isn't just having fat deposits, it's the body's reaction to those deposits.
Exactly. And this understanding leads us straight to a concept that's absolutely central to this new statement: residual inflammatory risk.
Residual inflammatory risk. Okay, break that down.
It describes the significant cardiovascular risk that persists in many patients, even when their traditional risk factors, especially LDL cholesterol, are optimally managed.
So my patient has textbook LDL, maybe under 70 milli-GDL, because they're on a potent statin, their blood pressure is good, but they still have an event, that leftover risk. That's the residual inflammatory risk.
That's very likely it. They've hit the lipid targets, but they're still carrying this simmering, low-grade inflammatory burden. And the main way we measure that burden is with high-sensitivity C-reactive protein, or hsCRP. This is the risk factor that we've largely been missing, or at least not systematically targeting.
Right. And to really get this, we need to understand the language, the science behind it. The statement mentions cardioimmunology as this emerging field.
Yes, it's the intersection of heart disease and the immune system.
Yeah.
It's fascinating. And the statement uses a few specific terms to capture the nuances of inflammation. We should probably unpack those.
Definitely. Makes it less abstract.
Okay, first up is parent inflammation. Now, when most people hear inflammation, they think of, a cut finger, red, hot, swollen, painful. Acute inflammation.
Yeah, the obvious kind.
Parent inflammation is different. It's low grade, it's chronic, it's often subclinical, meaning the patient doesn't necessarily feel it directly. It's triggered by milder, persistent stress or tissue dysfunction.
So not a 5-alarm fire, more like a constant low hum of background static.
That's a great way to put it. It's not enough stress to cause an immediate overwhelming crisis, but it's enough to disrupt normal tissue function and drive slow, harmful changes over time. We see this chronic remodeling process a lot in conditions like heart failure, which we'll probably touch on later.
Okay, parainflammation, the low, slow burn. Got it. What about efferocytosis? Sounds very technical.
It is, but it's a beautiful process, actually. Efferocytosis is basically the body's specialized garbage disposal system for dead cells. When cells undergo programmed death, apoptosis, they need to be cleared away efficiently. Efferocytosis is how immune cells like macrophages engulf and remove these dead cells.
Yeah.
And the crucial part is they do it quietly, without triggering a big inflammatory alarm.
So it's like a stealth cleanup operation, prevents the debris from causing more trouble.
Exactly. It's essential for resolving inflammation. If efferocytosis breaks down, which can happen in atherosclerosis, that cellular debris piles up, becomes toxic, and actually fuels more persistent inflammation. It highlights that stopping inflammation isn't enough. You also need effective cleanup.
That really underscores the complexity, and it makes the shift in recommendations even more stark. You mentioned earlier that back in 2002, a joint statement actually advised against routine inflammatory marker screening. That's a complete turnaround.
It's huge, isn't it? It just shows how far the science has come. Back then, the evidence wasn't quite there. There were concerns about test standardization, whether the markers really added much predictive value beyond traditional factors, and critically, whether we could even do anything about inflammation therapeutically. But the 2025 statement makes it clear. Massive progress has been made. Basic science, clinical studies, large population studies, and most importantly, big outcome trials have now shown unequivocally that lowering inflammation, even independently of lowering cholesterol, reduces cardiovascular events.
The proof is in the pudding, basically.
Pretty much. The evidence is now solid enough to say this chronic, low-grade inflammation is fundamental to atherosclerosis, and we absolutely need to assess it universally.
Okay, so we understand why inflammation matters. Now, how do we measure it? The ACC is really zeroing in on hsCRP, and they're recommending universal screening. Why universal? Why not just test people we already think are high risk?
The statement gives a very practical, almost blunt reason. Because clinicians will not treat what they do not measure. It's that simple. If we don't routinely look for this risk factor, which affects a huge chunk of the population, maybe up to 50% of adults have levels indicating some elevated risk, then we're going to miss millions of people. People whose cholesterol looks fine, but who are walking around with this significant inflammatory danger.
So making it universal forces us to confront it.
Exactly. It needs to be part of the standard cardiovascular risk assessment, right alongside cholesterol panels and increasingly lipoprotein A or LPA. This applies both in primary prevention, people without known disease, and secondary prevention, those who've already had an event.
Okay, so we run the hsCRP test, we get a number back. What do we do with it? What are the levels that should make us pay attention?
The statement provides clear, actionable risk categories based on hsCRP levels. And they argue the prognostic value here is right up there with blood pressure or cholesterol. So if the hsCRP is less than 1 milligl, that's considered lower relative cardiovascular risk. Good news, if it's between 1 and 3 milligl, that's classified as average relative risk, kind of the middle zone. But the real action trigger is an hsCRP level greater than 3 milligl. That puts the patient in the higher relative cardiovascular risk category. And that finding should definitely prompt a clinical discussion and potentially change in management.
Greater than 3 milligl is the key threshold. But practically speaking, what if someone just has a cold or maybe twisted their ankle? Their CRP will shoot up, right? How do we avoid basing long-term risk on a temporary spike?
That's a critical point, and the statement addresses it directly. If you get an initial hsCRP result that's really high, say over 10 milligl, that strongly points towards an acute temporary inflammatory state, like an infection, an injury, or maybe an autoimmune flare-up, you absolutely should not use that high number for assessing long-term cardiovascular risk. The protocol is clear. Repeat the test in about 2 to 3 weeks once the acute issue is hopefully resolved.
And then which value do you use?
You use the lower of the two values for predicting long-term risk. The goal is to capture the patient's baseline chronic inflammatory state, not a fleeting acute response.
Makes sense. Now here's where things get, well, almost unbelievable, challenging decades of dogma. The report talks about data comparing hsCRP head-to-head with LDL cholesterol for predicting future events, especially long-term. What did they find?
Yeah, this is really paradigm-shifting stuff. The statement highlights evidence suggesting that the long-term prognostic information you get from a single hsCRP measurement is, at a minimum, as powerful as what you get from LDL cholesterol. There's one particularly striking study. They cite a large prospective study of nearly 28,000 initially healthy women followed for 30 years.
30 years, wow.
Right. And what they found was that a single hsCRP measurement taken at the start provided a greater spread of risk over those 3 decades compared directly with LDL cholesterol or even LPA.
Wait, a greater spread of risk? How can that be? LDL is the physical stuff in the plaque. CRP is just an inflammatory marker that goes up and down. How can it predict risk better over 30 years?
It's a fascinating question, isn't it? It suggests that maybe the underlying chronic inflammatory tendency, the sort of genetic predisposition, the lifestyle factors, the immune system's baseline activation level, might be a more robust long-term predictor of who will eventually have that plaque rupture than simply the amount of cholesterol present at one point in time.
Well,
It implies that if your immune system is constantly simmering, constantly prone to overreacting, that state itself is incredibly dangerous over the long haul, perhaps more so than just having a bit more building material around.
That really reframes things. If your body is always on alert, it's going to cause trouble eventually, regardless of the exact LDL number.
That seems to be the implication. And it strongly reinforces why universal HSCRP screening is now being pushed so hard.
So HSCRP is the go-to marker, largely because it's validated in all the big outcome trials showing treatment benefit. Are there other inflammatory biomarkers lurking in the background that might be useful one day?
There are definitely others. Researchers are interested in things like interleukin-6 or IL-6, which is upstream of CRP, fibrinogen, even simple ratios like the neutrophil to lymphocyte ratio from a standard blood count. But for now, the consensus view reflected in the statement is that routinely measuring these others doesn't add enough independent prognostic information beyond what HSCRP already gives us to justify their use in everyday clinical practice. HSCRP is reliable, standardized, cheap, and it's the one tied to proven therapies, so it remains the standard.
Okay, so blood tests give us HSCRP. What about actually seeing the inflammation in the arteries? Are imaging techniques helpful here?
Imaging is definitely a hot area of research, but it's mostly still in the research realm, not quite ready for routine prime time. Techniques like specialized CT scans, cardiac MRI, or PE taps using a radioactive tracer called FDG can indeed visualize inflammation within the plaque itself or in the tissues surrounding the blood vessels. Perhaps the most exciting emerging non-invasive marker right now is something called the Perivascular Fat Attenuation Index, or FAI.
FAI, measuring the fat around the artery. Why is that important? We usually focus on what's inside the artery, like calcium.
That's the key difference. A coronary calcium score tells you about the burden of old, stable, calcified plaque, often called cold plaque. It's a measure of lifetime atherosclerosis burden, but it doesn't necessarily tell you about current danger or instability. FAI, derived from standard cardiac CT scans, measures changes in the density and composition of the fat tissue directly surrounding the coronary arteries. It turns out that when an artery segment is highly inflamed hot, it releases inflammatory signals that change the nature of that adjacent fat.
So FAI is like a thermometer for the artery wall. It detects active inflammation.
That's a good analogy. It seems to identify coronary arteries that are metabolically stressed and potentially vulnerable to rupture, and it provides this information independently of the calcium score.
yeah.
You could have a low calcium score but a high FAI, suggesting hidden danger or vice versa.
Very cool, but still mainly research for now.
Yes. The consensus is that while FAI and other advanced imaging techniques are incredibly promising for research and understanding the disease better, they aren't recommended for routine clinical use just yet, but definitely point towards a future of more personalized, inflammation-focused risk assessment.
All right, knowledge is great, but action is better. This is the core of the statement. What do we actually do about this inflammation? Let's start with primary prevention, trying to stop that first heart attack or stroke.
A key concept here is the patient who is sometimes called SMRF-less but inflamed. SMRFs are the standard modifiable risk factors, high blood pressure, high cholesterol, diabetes, smoking.
Right, the usual suspects.
Well, the data clearly shows that having an elevated HSCRP predicts future coronary heart disease events even in people who don't have any of those traditional SMRF-offs. They look healthy on paper by the old rules.
But they're walking around with this hidden inflammatory risk. And you said earlier that could be up to half the adult population in the U.S. with HSCRP equals 2 milligl.
Exactly. It's a massive group that was previously flying under the radar. And this is precisely the population that the landmark Jupiter trial focused on.
Jupiter. That one really changed things, didn't it?
Absolutely pivotal. Jupiter enrolled people who had normal or low LDL cholesterol, specifically less than 130 milligdl, but who had elevated HSCRP, defined as 2 milligl or higher. So, low lipid risk by old standards, but high inflammatory risk.
And they treated them with a statin, rosustatin, even though their LDL wasn't high. What was the thinking there?
The hypothesis was that statins do more than just lower LDL. They have these other effects, called pleiotropic effects, and a major one is reducing inflammation. Jupiter was designed specifically to test if that anti-inflammatory effect alone could provide benefit in this group. They used a moderate dose, 20 milligrams of rosuvastatin.
And the results were dramatic.
So dramatic, the trial was stopped early by the Data Safety Monitoring Board. Treatment with rosuvastatin led to a 47% reduction in the primary endpoint, major cardiovascular events like heart attack, stroke, or cardiovascular death.
47% reduction in people who didn't even have high cholesterol to begin with.
Exactly. It was stunning proof that the anti-inflammatory action of statins is a major independent benefit. It cemented the idea that statins aren't just lipid drugs, they're vascular anti-inflammatory drugs too.
So what's the takeaway for primary prevention now? If I find someone with hsCRP over 3 milligl, even if their LDL is okay.
The consensus recommendation coming out of Jupiter and subsequent analyses is clear. Finding a persistently elevated hsCRP, especially above that 3 milligl mark in someone without known CVD, should make you strongly consider starting or intensifying statin therapy, pretty much regardless of their baseline LDL level.
Yeah.
The decision is driven by the inflammation.
That's a big change in practice. But before jumping to statins, the statement emphasizes lifestyle first, right?
Absolutely. Lifestyle modification is always the foundation. If you identify someone with this inflammatory burden, especially if it's borderline or moderately elevated, the very first step is intensive lifestyle counseling. This should be a wake-up call for the patient to really focus on weight management, quitting smoking if they smoke, adopting a heart-healthy anti-inflammatory diet, and getting regular physical activity. Often, these changes alone can significantly lower hsCRP and reduce risk.
Okay, now let's shift to secondary prevention. These are patients who already have known cardiovascular disease. They've had a heart attack or a stent or bypass surgery. They're usually already on statins, often high-intensity ones. What about inflammation in this group?
This is where that concept of residual inflammatory risk is arguably most critical. Even among patients treated aggressively with statins, maybe achieving LDL levels well below 70 milligdl, if their hsCRP remains elevated, say, above 2 milligdl, their risk of having another event is still substantially higher. In this secondary prevention setting, hsCRP is at least as powerful a predictor of recurrent MI, stroke, or death as the LDL cholesterol level itself. So we desperately needed ways to target that leftover inflammatory risk directly.
And this need led to the development and testing of specific anti-inflammatory drugs beyond statins. The big proof of principle trial here was CANTOS, right, using canakinumab.
Exactly. CANTOS was revolutionary. It took patients who had a prior heart attack and persistently elevated hsCRP above 2 milligl despite statin therapy. And it tested canakinumab, which is a monoclonal antibody that specifically targets and blocks a key inflammatory molecule called interleukin-1 beta, IL-1.
Why target IL-1 specifically?
Because IL-1 is thought to be a master switch, sitting high up in the inflammatory cascade that drives atherosclerosis. Blocking it was hypothesized to shut down downstream inflammation, including the production of IL-6 and CRP, without affecting cholesterol levels at all.
Right.
CANTOS was designed to see if pure anti-inflammatory therapy worked.
And did it? Was the principle proven?
Yes, it was. Canakinumab significantly reduced the rate of recurrent cardiovascular events, heart attack, stroke, CV death, by about 15% to 17% compared to placebo. And the crucial finding was that this benefit occurred with absolutely no change in LDL or HDL cholesterol levels.
Wow, so undeniable proof that lowering inflammation itself prevents events.
Precisely. It fundamentally validated inflammation as a therapeutic target in its own right.
But canakinumab isn't something we routinely use for heart patients now, is it? What were the downsides?
Right. While CANTOS was a scientific triumph, canakinumab is very expensive. And importantly, the trial showed a small but statistically significant increase in the risk of serious, sometimes fatal infections. Patients on canakinumab were slightly more likely to get infections. There were also some interesting potential benefits seen, like lower rates of gout and even lung cancer, but the infection risk and cost have limited its widespread use for CVD. It really paved the way conceptually, though.
Okay, so if canakinumab was the proof of concept, what's the practical, accessible drug that came next and is being used now to target this residual risk?
That would be low-dose colchicine. Colchicine is an ancient drug actually used for centuries for gout. It's inexpensive and works by interfering with inflammatory cells, particularly neutrophils. Two major trials, LODOCO-2 and COLCOT, tested low-dose colchicine, usually 0.5 milligrams once daily, in patients with stable chronic coronary disease who are already on standard therapies like statins.
And what did those trials find?
They both showed pretty remarkable results. Adding low-dose colchicine reduced the risk of recurrent major cardiovascular events by about 25% on top of standard care.
25%. That's a substantial benefit from such a cheap old drug.
It really is. It offers a highly cost-effective way to address that residual inflammatory risk.
So what's the official status of colchicine now for heart patients?
Based on these trials, low-dose colchicine became the first anti-inflammatory drug specifically approved by the FDA as an add-on therapy to reduce cardiovascular risk in patients with established atherosclerosis. It's meant to be used in addition to lipid lowering and other standard preventative treatments, especially in those who still have evidence of inflammation, like hsCRP 2 mg.
Are there important caveats? Who shouldn't take it or when shouldn't it be used?
Yes, a couple of key points. First, the timing seems to matter. While it works well for chronic stable disease, some trials looking at starting colchicine immediately during an acute heart attack or unstable period haven't shown clear benefit, or the results are complex. So it seems best suited for chronic secondary prevention. Second, because of how it's metabolized and cleared, colchicine should generally be avoided in patients who have significant kidney or liver disease.
Good to know. And looking forward, if IL-1 worked conceptually and colchicine works practically, what's next? Are researchers targeting other parts of that inflammatory cascade like IL-6?
Absolutely. IL-6 is the direct downstream product of IL-1 signaling and also a major driver of CRP production. So it's a very logical next target. There are several large clinical trials ongoing right now testing specific IL-6 inhibitors, like a drug called ziltivekimab. These trials are focusing on very high-risk populations who often have significant inflammation, such as patients with chronic kidney disease, heart failure with preserved ejection fraction, HFpEF, or those recovering from an acute coronary syndrome. The results are eagerly awaited.
Okay, we've covered the medical interventions, but the ACC statement puts huge emphasis on lifestyle. It suggests our daily behaviors are maybe the most powerful anti-inflammatory tools we have. Let's start with diet. What kind of eating patterns really help fight inflammation?
The evidence strongly points towards whole food, predominantly plant-based dietary patterns. The two most well-studied and recommended are the Mediterranean diet and the DSH, dietary approaches to stop hypertension diet. What they have in common is an emphasis on lots of fruits, vegetables, whole grains, legumes, nuts, and seeds, often using olive oil as the primary fat source. And critically, they involve minimizing the intake of pro-inflammatory foods.
Which are?
Things like red and processed meats, refined carbohydrates, white bread, sugary snacks, and sugar-sweetened beverages. These tend to promote inflammation in the body.
And we have solid trial evidence that these diets work, right? Like the pre-DMED trial.
Exactly. Predimed was a large randomized trial in Spain that showed people assigned to a Mediterranean diet, particularly when supplemented with extra virgin olive oil or mixed nuts, had significantly lower levels of inflammatory markers like hsCRP, and importantly experienced fewer major cardiovascular events compared to those on a standard low-fat controlled diet. It really validated these patterns as therapeutic.
Okay, diet is key. What about omega-3 fatty acids? There's been a lot of back and forth on those over the years. What's the current thinking?
The statement provides pretty clear guidance here. The primary recommendation is to get more omega-3s, specifically EPA and DHA, through diet, ideally by eating 2 to 3 servings of fish per week, especially fatty fish like salmon, mackerel, herring, or sardines. The observational evidence linking higher blood levels of EPA and DHA with lower risks of heart disease, stroke, and overall mortality is really quite strong and consistent. What's also become clear is that there seems to be a dose-dependent effect. Meta-analyses pooling data from various studies suggest that for every extra gram per day of combined EPA and DHA consumed, there's roughly a 7–9% lower risk of heart attack or coronary heart disease.
So maybe some earlier supplement trials failed because the doses were just too low.
That's a leading hypothesis. You might need a fairly substantial intake, likely more than 1 gram per day, to see a significant cardiovascular benefit from supplements alone.
But is there any downside to high-dose supplements? I feel like I heard something about atrial fibrillation risk.
Yes, that's an important nuance the statement addresses. Some meta-analyses of trials using high-dose omega-3 supplements, generally over 1 gram a day, have found a potential association with a slightly increased risk of developing atrial fibrillation, or AFib. However, and this is key, this increased AFib risk was not seen in large studies looking at people who got their omega-3s simply by eating fish regularly.
Interesting. So getting it from food seems safer in that regard.
It appears so. The recommendation remains primarily focused on dietary fish intake as the preferred and likely safest way to boost omega-3 levels. High-dose supplements might be considered in specific situations, but the potential AFib risk needs to be part of that discussion.
Now, there's this really fascinating cutting-edge area related to omega-3s, specialized pro-resolving lipid mediators, or SPMs. What on earth are those?
The SPMs are amazing molecules. They're actually derived from omega-3 fatty acids like EPA and DHA within our bodies. But they aren't just passive bystanders. They are bioactive lipids that play a crucial role in actively resolving inflammation.
Resolving it, so not just preventing it, but actually shutting it down once it starts.
Exactly. That's the key difference. They don't primarily work by blocking the start of the inflammatory response. Instead, they orchestrate the cleanup phase. They do things like stop inflammatory cells from migrating into tissues, and importantly, they strongly promote that efferocytosis process we talked about earlier, the efficient clearance of dead cells and debris. They basically tell the immune system, okay, the danger has passed, time to clean up and go back to normal, and they do this without causing broad immunosuppression.
Wow, so they're like the immune system's peacemakers and cleanup crew combined.
That's a perfect description. And this isn't just theoretical. Lower levels of certain SPMs have been linked to worse outcomes, and higher levels seem to predict whether atherosclerotic plaques will actually regress or shrink over time. It highlights how important the resolution phase of inflammation is.
Which suggests that maybe boosting our body's own SPM production could be therapeutic, perhaps through diet and lifestyle.
That's exactly where the research is heading. Which brings us nicely to the other lifestyle pillars: exercise and smoking.
Right. Standard advice, but how do they tie into inflammation specifically?
Exercise is a potent anti-inflammatory intervention. The standard recommendation holds. Aim for at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic activity per week. How does it work? Multiple ways. Exercise reduces the production of pro-inflammatory cytokines. It improves insulin sensitivity. And interestingly, exercise has been shown to increase the body's production of those beneficial SPMs. So it literally helps your body resolve inflammation better.
So exercise helps clean up the internal mess. What about smoking?
Smoking is just disastrous for inflammation. It's a major driver of chronic, low-grade systemic inflammation. It bombards the body with oxidants and toxins that constantly activate the immune system. Worse still, smoking actively impairs the function of resolvins and other SPMs. It basically sabotages your body's natural ability to turn off inflammation and clean up damage. Quitting smoking is absolutely non-negotiable if you want to lower inflammatory risk.
We focused heavily on atherosclerosis, the buildup of plaque. But the ACC statement also discusses inflammation's role in other heart conditions, like heart failure or HF. How does inflammation play out differently there? Hashtag tag 5A, heart failure, HF.
Heart failure involves significant immune system activation, both systemically, throughout the body, and locally within the heart muscle itself. The type of inflammation here is often described using that term we introduced earlier, perinflammation.
Right, the chronic, low-grade, simmering response.
Exactly. In HF, it's often driven by ongoing stress on the heart muscle, maybe from high blood pressure, a previous heart attack, or valve problems. This persistent stress triggers a low-level chronic immune response. Its immune activation, dysregulation, and chronic inflammation contribute directly to the harmful changes we see in the heart muscle in HF, what's called pathological remodeling. Immune cells like macrophages and T cells actually infiltrate the failing heart tissue and are linked to disease progression and even arrhythmias. Cardioimmunology is really unlocking how central the immune system is to HF.
Okay, so if inflammation is clearly involved, have anti-inflammatory drugs worked for treating heart failure? I seem to recall some big trials failing years ago.
You're right. The history there is definitely mixed. Early attempts using broad anti-cytokine drugs, particularly those targeting TNF-alpha, like infliximab or etanercept, were largely disappointing in large trials of chronic heart failure patients. They didn't improve outcomes and sometimes even seemed to worsen things.
So just broadly suppressing inflammation wasn't the answer for HF?
It seems not. The immune response in HF is complex, maybe with both harmful and potentially protective roles at different stages. A blunt approach didn't work.
But have there been any successes more recently?
Yes, there have been some glimmers of hope, particularly when targeting specific pathways or patient groups. Remember the CANTOS trial with canakinumab, the IL-1 blocker?
Yeah, the atherosclerosis trial.
Well, an analysis within CANTOS looked specifically at heart failure outcomes. It found that canakinumab actually led to a dose-dependent reduction in hospitalizations for heart failure and composite HF events, especially in those post-MI patients who started with elevated hsCRP. This was really the first major signal that targeting a specific cytokine pathway might benefit certain HF patients, particularly those with significant baseline inflammation after a heart attack.
Interesting. Any other successes? What about omega-3s?
Yes, the GCHF trial was another positive signal. This large trial tested 1 gram daily of omega-3 fatty acids, EPADA, in patients with established symptomatic heart failure, NYHA class 2Phe. It found a modest but statistically significant reduction in all-cause mortality and cardiovascular hospitalizations over several years, and this benefit seemed to apply regardless of the underlying cause of HAF or the patient's ejection fraction.
Okay, so for heart failure, what's the bottom line from the statement? What can we potentially use now?
The consensus suggests that measuring inflammatory markers like hsCRP or IL-6 can be useful for risk stratification in HF patients. Patients' higher levels predict worse outcomes. Therapeutically, clinicians should consider recommending omega-3 fatty acid supplementation, like the 1 day dose used in GCHF, for patients with symptomatic NYHA class DOA AV heart failure. And similar to primary prevention, statins may be considered for HF patients if their heart failure is due to underlying ischemic heart disease, coronary artery blockages, and they are over age 60, again leveraging those pleiotropic anti-inflammatory benefits. Hashtag 5V, recurrent pericarditis.
Let's switch gears to another condition where inflammation is front and center. Recurrent pericarditis, inflammation of the sac around the heart. Here, anti-inflammatory treatment is standard, isn't it?
Absolutely. For pericarditis, anti-inflammatory therapy is the standard of care. For an initial episode of acute pericarditis, the guidelines strongly recommend using low-dose colchicine for 3 months, in addition to traditional antacids. This is based on trials like ISAP, which showed that adding colchicine cuts the risk of the pericarditis coming back recurrence by about 50%. It's highly effective first-line therapy.
But what about those really tough cases? Patients who keep having recurrences despite colchicine, maybe they need steroids, and their inflammation markers like hsCRP stay high.
That's where we've seen major therapeutic breakthroughs recently, specifically targeting the IL-1 pathway, similar to what was explored in CANTOS but applied much more successfully here. For these high-risk patients with multiple recurrences or resistance to standard therapy, IL-1 blockade has been a game-changer. Trials using drugs like anakinra, studied in AirTrip, or Rilonacept, studied in Rhapsody, have shown dramatic reductions in recurrence rates.
How dramatic.
For instance, in the AirTrip trial with anakinra, patients who have been experiencing frequent, debilitating recurrences saw their recurrence rate drop from around 90% down to just 18%. It's truly life-altering for these patients. These IL-1 blockers are now becoming the go-to therapy for difficult, refractory, recurrent pericarditis, especially when inflammation is clearly driving the process. For example, hsCRP 10-LGL.
Is there any specific caution with these potent IL-1 blockers?
Yes, a geographic consideration mainly. Because IL-1 is involved in fighting certain infections, these drugs need to be used cautiously or avoided in parts of the world where tuberculosis, TB, is a very common cause of pericarditis. You wouldn't want to suppress the immune response needed to control TB.
This statement clearly synthesizes a huge amount of progress, but science never stops. What does the ACC see as the major remaining knowledge gaps? Where does research need to go next in understanding inflammation and heart disease?
Well, despite all this progress, the statement acknowledges that the really intricate interplay between inflammation and other major body systems is still incompletely examined. We need a much deeper understanding of exactly how chronic inflammation interacts with, say, the neuroendocrine system, think stress hormones like cortisol, or the cardiometabolic system involving insulin resistance and diabetes, and of course the vascular endothelium, the lining of the blood vessels itself. These systems are all interconnected, and untangling those complex feedback loops is crucial for developing even better therapies.
And one really hot area that connects inflammation, aging, genetics, and heart risk is this thing called CHA. Can you explain what that is?
CHIP stands for clonal hematopoiesis of indeterminate potential. It sounds complicated, but the basic idea is this. As we age, the stem cells in our bone marrow that produce blood cells can acquire spontaneous mutations in certain genes. Sometimes one of these mutated stem cells starts dividing more rapidly than its neighbors, creating a large clone of identical blood cells all carrying that mutation. If this clone gets large enough but hasn't yet caused a full-blown leukemia or blood cancer, we call it CHIP.
Okay, so it's like a pre-malignant state in the blood cells. Why is that relevant to the heart?
Because it turns out that some of the most common genes mutated in CHP, like TAT2 or DNMT3A, make the resulting blood cells, especially inflammatory cells like macrophages, hyperinflammatory. They're basically primed to cause more inflammation. And the clinical data is striking. Having CHP is independently associated with about a twofold increased risk of developing cardiovascular disease, like heart attacks and strokes. It acts like a genetic amplifier for chronic inflammation and atherosclerosis.
Twofold risk, that's significant. It's like your own blood cells are contributing to the problem.
Exactly. And this leads to a really fascinating finding highlighted in the statement from an exploratory analysis of the CANTOS trial data.
What did they find regarding CHIP and the IL-1 blocker?
They looked at patients in the trial who happened to carry CHIP mutations, specifically in the TT2 gene. And in those individuals, treatment with canakinumab resulted in an absolutely massive 62% reduction in the risk of major cardiovascular events.
62%, compared to the overall 15-17% reduction.
Yes, it suggests that if you have the specific genetic driver of inflammation, TET2 mutant CHIP, then an anti-inflammatory therapy targeting the IL-1 pathway works dramatically better for you.
That's incredible. It's like a blueprint for a personalized anti-inflammatory therapy. Find the patients whose inflammation has this specific genetic root and target it.
Precisely. It points towards identifying specific inflammatory endotypes, subtypes of disease, driven by distinct mechanisms that will respond best to particular immunomodulatory therapies.
So based on all these gaps and opportunities, what are the key research priorities outlined in the statement?
Several big ones stand out. First, we really need large randomized trials testing anti-inflammatory therapies, maybe even low-dose colchicine, specifically for primary prevention. Can we safely prevent the first heart attack in healthy people who just have elevated hsCRP? Second, we need to continue developing and validating better imaging techniques like FAI to non-invasively visualize and quantify inflammation in coronary plaques, especially the dangerous non-calcified ones. We need to bring these tools from research into routine practice. Third, more work is needed, especially in heart failure, to define those specific patient subtypes or endotypes based on their inflammatory profile, so we can target therapies like IL-1 or IL-6 inhibitors to those most likely to benefit. And finally, there's a huge need for implementation science. We have the evidence now for hsCRP screening and for using colchicine in secondary prevention. But how do we ensure these evidence-based practices are actually adopted consistently in busy clinics around the world? We need strategies to overcome barriers to implementation.
That makes perfect sense. It's one thing to know what works, another to get it done routinely. So, wrapping up the core message for everyone listening.
The message is loud and clear. The era of just thinking about inflammation is over. We are now firmly in the era of acting on inflammation. It's clinically actionable. Clinicians need to embrace routine hsCRP screening, identify that residual inflammatory risk, and use the evidence-based tools we have, starting with intensive lifestyle changes, optimizing statins, and strongly considering low-dose colchicine for secondary prevention patients to tackle this fundamental driver of cardiovascular disease.
Well, that was incredibly insightful. A really thorough exploration of this huge shift in understanding cardiovascular risk. If we had to boil it down to the 3 absolute must-remember points for you, our listeners, I'd say they are. 1, the critical importance of universal hsCRP screening. This marker gives us powerful long-term risk information, potentially even more than LDL alone, and we can't treat what we don't measure. 2, the profound impact of lifestyle, especially anti-inflammatory diets like Mediterranean or DASH, and regular exercise, not just for prevention, but potentially for actively resolving inflammation through mechanisms like boosting SPMs. And 3, the proven role of low-dose colchicine as an effective, accessible tool for reducing recurrent events in secondary prevention patients who still carry that residual inflammatory risk despite good cholesterol control.
And maybe one final thought to leave you with, something that looks even further upstream. We're now seeing that a significant number of adolescents, maybe 15% or more in the U.S., already have elevated hsCRP levels. This inflammatory burden often appears before traditional risk factors like high blood pressure or high cholesterol even develop. So the provocative question is, how do we need to adapt our public health and prevention strategies to address inflammation much earlier in life, perhaps aiming for primordial prevention to stop the fire before the traditional risk factors even get a chance to smolder? Something to think about.
Thank you for watching The Funnel Effect.